I think we can start the session now. Okay. Okay, fine. Yes. Good evening, everyone. I am Dr. BANDALA RAJAN, your ADR faculty for dermatology. Today we are going to see about INICET dermatology test and discussion. The 50 questions we gave along with radiology, 90 questions total. From 41 to 90, those questions we will discuss today. And some important points related to it, so it will be helpful for your subsequent INICET exam. The first question: all are features of tuberous sclerosis except option A, adenoma sebaceum, option B, lesion nodules, option C, ash leaf macules, option D, shag-green patches. So it is a straightforward question. You should know that cutaneous manifestations of tuberous sclerosis. For that, I will just help you with some easy mnemonic, like there is one macule in tuberous sclerosis, one papule, one patch, and one nodule. So all the common features are there: macule, papule, patch, and nodule. If you see macule, it is ash leaf macules. In papules, it is adenoma sebaceum. Adenoma sebaceum is basically a misnomer, which is basically an angiofibromas. There is no adenoma. It is not of sebaceous origin. It is an angiofibroma. It's a misnomer. In patch, it is shag-green patch. In nodule, it is known as Coinen tumor or Coinen nodule or periangular fibroma. Now we will see the options again. We have already discussed there is a macule in tuberous sclerosis, which is ash leaf macule, so it is out. And there is a patch, shag-green patch, that is also out. The papular lesion is known as adenoma sebaceum, that is also ruled out. So the answer is lesion nodules. Lesion nodules are seen in neurofibromatosis, especially in the iris. So the answer here is lesion nodules. Then this another important thing you need to know is which of the following skin manifestation is first to occur in tuberous sclerosis. We know macule is the first one, so you can remember easily. It is the first one to occur. Ash leaf, leaf-like or lanceolate-like macules. So macule is ash leaf macule, papule is adenoma sebaceum, patch is shag-green patch, nodule is Coinen tumor or periangular fibroma. Other skin and mucosal manifestations are dental enamel pits, confetti-like hypopigmentation. Here you can make out multiple dot-like lesions. And gingival fibroma also can happen. So these are things you should remember. Apart from that, tuberous sclerosis, you should remember a mnemonic, epiloia. That is a basic thing. Like 3 things will be there: epilepsy, low IQ, adenoma sebaceum. Right? Next, this question is frequently asked in INICET exam. They will give the image and they will ask what morphology it is. Like in this question, they asked identify the morphology of following skin lesion. Option A is discoid, option B is nummular, option C is annular, option D is targetite. Please look at the lesion very closely. There is a central white area or central blister, it may be, and there is an erythematous area followed by a paler, followed by a again erythema. It is a classical targetite skin lesion. So the answer here is targetoid. Now we will see how discoid, nummular, annular lesions looks like. Here, if you see in this lesion, it is a case of psoriasis, by the way. If you see this lesion, the entire lesion is elevated, right? Or coin shape. You can remember a coin. If the lesion is looking like a coin, the entire thing is elevated, which is known as discoid or nummular. Both are same. If you are seeing a lesion which is like the periphery is only elevated, the center is clear, something like a bangle, you can remember. Bangle, there is a peripheral prominence with the central clearance, which is annular. This one we have already discussed, which is target or targetoid lesion. If they have 3 zones, it is targeted. Less than 3 zones means 2 zones, which is targetoid, we will tell. Other possible patterns they may ask is this one. Here, if you see the back to abdomen, the lesions are arranged in a linear pattern. We know this is a dermatomal pattern or zoosteriform pattern, right? Or zoosteriform. Means it involves only one dermatome, one area of skin supplied by a single nerve root. This is like serpiginous skin lesion. It's good if you are knowing 1 or 2 examples for each. Like for discoid lesion, the example we told plaque psoriasis. Discoid eczema. For annular lesion, the common thing we know is tinea corporis. Other than that, granuloma annulare, which is also an annular lesion classically, the name itself implies, na? Next, for target lesion, you have to remember one thing, which is erythema multiforme, which also can be asked. Erythema multiforme is characterized by which type of skin lesion? Dermatomal, which is characteristic of herpes zoster, which is an viral infection. Serpiginous, you can remember cutaneous larva migrants. These are some examples, important examples you should know. Next, we'll move on to the next question. Sebaceous gland secretion is characterized by A. holocrine secretion, B. eccrine secretion, C. merocrine secretion, D. apocrine secretion. This question, many of you got confused. What is the correct answer? For that, we should know first what are these secretions means. Eccrine, merocrine, apocrine, holocrine. Eccrine gland or eccrine is otherwise known as merocrine. Both are same. Just for confusing, I have given that option. Eccrine or merocrine, if there is a cell, glandular cell with substances, only the substance will be released, which is eccrine secretion. In apocrine, there is a cell, the apical portion of the cell will be broken out and the substance will be released. So it is apocrine. In holocrine, whole cell will be disintegrated. Whole cell disintegrates. You can easily remember the examples. Eccrine, the example is eccrine sweat glands. For apocrine, apocrine sweat glands. Sebaceous gland is basically a holocrine gland, that you should remember. Eccrine and apocrine are easy to remember, na? Only sebaceous gland you should remember, which is an holocrine gland. The entire cell disintegrates and releases sebum. Some important points you should remember in this. For example, in apocrine. For apocrine sweat gland and sebaceous gland, they both open into hair follicle. Eccrine sweat gland directly into skin. Skin, the portion is known as acrosyringium. Right? Another important point you should remember is modification of apocrine glands. Example, mammary gland. Ceruminous glands of ear. And moles gland of eye. These are the modifications. For sebaceous gland, one thing you should remember is 4-day spots. Four-day spots, which is ectopic sebaceous glands. Glands in maybe lips, penis, vulva, etc. One confusing thing they may ask is Fox 4-day spots, which is an apocrine origin. Fox 4-day spots. So 4 days is of sebaceous gland. Fox 4 days is apocrine in origin, which is basically apocrine miliaria. Normal prickly heat we are having, na, that is eccrine in origin. That is eccrine miliaria. These are things we should know from these topics: eccrine, apocrine, and holocrine glands. So now we can answer this question. A sebaceous gland secretion is characterized by holocrine secretion, right? Fine. Next question. A farmer presented with itchy rashes over the face, including periorbital region and flexures. What is the likely allergen? Option A, parthenium. Option B, PPD. Option C, hexachromate. Option D, nickel. This was asked multiple times in INICET. Even in previous NEET exam, they have asked somewhat similar question. For a hair dye, they have asked. Now they are asking for a farmer this question. So the clues here are: the patient is a farmer by occupation. Second, the lesions are itchy rashes over the face, including periorbital region and flexures. So whenever there is a history of farmer with itchy rashes over the face and flexures, so it is of parthenium, because parthenium flower present everywhere in the field and all, na? It is like a weed, so it will cause allergy, especially wherever the pollen will settle. Especially the pollen will settle on the flexures, something like upper eyelid, behind the ear, chin area, below the nose, flexures and all. So it will drop there and it will settle there and it will trigger the allergic contact dermatitis. So the answer here is parthenium. So the clue here is farmer and involvement of periorbital region and flexures. So example like this: parthenium, pollens deposit in the exposed areas, deposit in folds or flexures. Wherever folds or flexures are there, it will deposit. Like I told, na, upper eyelid, behind ear, axilla and all. So it will create an allergic contact dermatitis in farmers. So this is very important. Apart from that, we should know other allergens which are given here, like PPD, hexachromate, nickel. If you see PPD, which is seen in hair dye, paraphenylene diamine. hair dye, which is very important. So the patient will have lesions over the face, scalp, in face especially near hairline, right? And also in the neck, nape of neck, where the allergen will drip down. Parthenium we have discussed in farmers. Hexachromate or potassium dichromate is common in cement. So you can easily remember, cement will deposit in the areas of contact like extremities commonly. Next, another one pending is nickel. Nickel is commonly present in the artificial jewelries. Artificial jewelries. Some utensils, daily utensils we are using, plates and all, it may be there. So it will be in the area of contact. Lesions in the area of contact. For example, neck, if they are wearing a chain, ear, they are wearing a earring and all. So some other points you should know is allergic contact. These are basically allergic contact dermatitis, which is a type 4 hypersensitivity reaction. That you should remember. The treatment of these is mainly avoidance of allergens. And treatment like steroids, immunosuppressants, right? Next, we will move on to the next question. A teenage girl presented with multiple nodules and cystic lesions over the cheek, the drug of choice. Option A, oral steroids. Option B, oral isotretinoin. Option C, topical steroids. Option D, topical clindamycin. First, we will read up the question. The patient is a teenage girl with the lesions, nodules and cystic lesions over the cheek. Most probably, the diagnosis is acne, of nodulocystic acne, to be precise. Nodules and cystic lesions in teenage girl is nodulocystic. If there is acne, automatically two options are ruled out. One is oral steroid, another is topical steroid. And the options pending are topical clindamycin and oral isotretinoin. Both are used in acne. The problem is like we have to see the grading of acne, which grade the patient is presenting with. There are 4 gradings. First grading is more of comedones. Second grading is more of papules. Third grading more of pustules. Fourth grading is more of nodulocystic lesions. If you see more of first or second type, it is more of topicals. Topical benzoyl peroxide, clindamycin, retinoids like adapalene and all will be helpful. If it is a third type, this topical plus oral antibiotics like oral doxy, azithro can be helpful, right? If it is nodulocystic acne, definitely the patient requires oral isotretinoin, which is an oral retinoid. So in this question, we will make out the patient is having very severe form of acne, so the patient will need oral isotretinoin. That is the correct answer. The pathogenesis, we know it is related to more sebum secretion, hyperseborrhea, more Cutibacterium, acne production, and inflammatory cascade. The beauty of acne is, although there are 4 different morphologies, most often all type of lesions coexist in acne. which is known as polymorphic. But if the acne is induced by some drugs like lithium, phenytoin, isoniazid and all, the lesions are monomorphic. Only one type of lesions will be present in that patients. Okay. Without comedones. Comedones won't be there in drug-induced acne, which is known as acneiform eruption. It's not exactly acne, which is an eruption due to drugs. Another important drug is steroids. In hormonal acne, it is associated with PCOD. The lesions are more in the jawline. And there will be hirsutism. And there will be female pattern hair loss, FPHL. These are things you should think in hormonal acne. It is associated with PCOD, more lesions in the jawline, lower jaw, and there will be hirsutism in females and female pattern baldness, especially in the midline widening in the females. These things you should remember. We will move on to next question. A patient presented with following skin lesions since birth. The diagnosis is option A albinism, option B focal vitiligo, option C pyrobialdism, option D segmental vitiligo. Here the image is given. If you see the image, it is an image of a child with the forehead and scalp is given. Here, if you make out, there is a depigmented macule in the midline along with the white forelock. If you are seeing this, it is directly towards pyrobialdism. Midline lesions with white forelock. White forelock with midline lesions. This of pyrobialdism. One important thing in pyrobialdism you should know, if the patient has pyrobialdism, along with the image you can make out, the color of the iris is different, right? Which is also known as heterochromia iridis. Along with it, the patient is having sensory neural hearing loss, which makes up a syndrome known as Waardenburg syndrome. That you should remember. Okay, this triad. So another thing, other options you will see, albinism, we know the entire skin will be white, which is due to defect in melanin synthesis because of tyrosinase enzyme mutation. Other options are focal vitiligo and segmental vitiligo. These two are somewhat very difficult to differentiate sometimes. If you see segmental vitiligo, which involves one segment, but focal vitiligo, here and there it will be there. That is the difference you should know. And it need not involve the midline. That is the differentiating feature between pyrobialdism and vitiligo. Vitiligo is an acquired condition more common in adults. In children also it can occur mainly segmental, but it don't involve midline. We will move to next question. A 75-year-old patient presented with the tense blisters over skin. Histopathology showed subepidermal cleft and IgG and C3 staining along the dermoepidermal junction on direct immunoflourescence. The target antigen is option A desmoglein 3, option B desmoglein 1, option C BP180, option D LAD1. Here we have to see the clues. First, the age. It is old age, very old age, 75. With tense blisters, subepidermal cleft with IgG deposits along the dermoepidermal junction. These are the clues. If you see in the old age, pemphigoid group of disorders are more common than pemphigus. Pemphigoid is more common. You see, nature of blisters, there are two types of blisters we know, flaccid and tense. If it is flaccid, it is pemphigus group of disorders. If it is tense, it is subepidermal. Like pemphigoid, BP, linear IgA disease, epidermolysis bullosa acquisita, etc. Mucous membrane pemphigoid. Linear IgA disease. Epidermolysis bullosa acquisita and all. And here if you see histopathology also, it is more of a subepidermal cleft. Subepidermal. So obviously desmoglein 3 and 1 are out, which are common in pemphigus group of disorders. So we are leaving with two things, BP 180, LAD1. BP 180 is associated with bullous pemphigoid, linear IgA disease associated with LAD1. So next if we are doing DAF, if it is showing IgA, which is towards linear IgA disease, if it is IgG, which is bullous pemphigoid. So the first clue is tense blisters. So the intraepidermal disorders are ruled out, like pemphigus group. So desmoglein 3 and 1 are out. DAF is showing IgG, which is specific towards bullous pemphigoid. If it is given IgA, it is towards linear IgA disease. Since IgG is given, the option here is BP 180. This is wrong because it is associated with linear IgA disease. The name itself, na, linear IgA disease. So you have to see step by step. First clue, second clue, third clue, fourth clue. So it will be easy for you to identify the answer. BP 180. Next question. Pseudocobna phenomena is seen in psoriasis vulgaris, vitiligo vulgaris, lichen planus, verruca vulgaris. Here, the options given are psoriasis, vitiligo, lichen planus, and verruca vulgaris. In these three are non-infectious. Only one condition is infectious, verruca vulgaris. We should know what is Kobna's phenomena before, so we can answer this question. Kobna's phenomena is appearance of these linear lesions along the line of trauma. Line of trauma or scratching or itching and all. Because whenever there is a trauma, there will be recruitment of inflammatory cells. If the patient is having psoriasis or vitiligo, what will happen? The inflammatory cells will be disease-specific inflammatory cells. Disease-specific cells. So what will happen? Whenever the wound heal, it heal with the lesions resembling the primary disease. Fine. Whenever there is a trauma, there will be a wound healing process. Na? So there will be more of disease-specific inflammatory cells. T cells will be recruited. So the lesions heal with the lesions resembling the primary disease. Pseudocobnar is not like that. Pseudocobnar is whenever you scratch the lesion, there will be auto-inoculation of inflammatory material, infectious material. Auto-inoculation, so the lesions will appear. Pseudocombner is basically seen in infections. To be precise, something like a wart, molluscum. Combner is seen in inflammatory conditions. Inflammatory diseases. Something like Sora, LP, vitiligo, etc. So now we can answer this question. Pseudocombner is seen in infections. So the option here is Verruca vulgaris, which is an infectious wart. Another interesting things we should know is reverse Combner. Whenever there is trauma, disappearance of lesions. Lesion disappear. Example is vitiligo is an example. Whenever we scrape the lesions, whenever we do a dermabrasion, the lesions will disappear. Apart from that, granuloma annulare. Granuloma annulare is annular lesions over the dorsum of hands, neck and all. Whenever you do a biopsy to diagnose the disease, I have noticed many times, almost 9 out of 10 times, within the biopsy report, the lesions disappear completely due to reverse Combner phenomena. Right? These are things you should know in this. Now, identify the wrong pair. These kind of questions are commonly asked in INICET. Like here, the thing is like disease and characteristic histopathological finding. Option A, diarrheal disease, Corrons. Haley disease, dilapidated brick wall appearance. C, psoriasis, Fortria microabscess. D, pemphigus megitans, eosinophilic microabscesses. In this, we will come one by one. Diarrheal disease, Corrons. Diarrheal disease is a dyskeratotic disorder which is characterized by Corrons. You can remember in this way. There are 2 R's in diarrheal. So 2 are Corrons. So which is a correct answer. So it is not answer. Corrons. So same. Haley disease. Dilapidated brick wall appearance. You can remember in this way. Haley disease. HH. So it is almost like a brick wall, na? So between the brick, there are gaps. So dilapidated brick wall appearance is seen in Haley. So which is also out. Now we will come to the abscess in subsequent slides. First you will see in detail about this. Diarrheal disease we know, which is an inherited acantholytic dyskeratosis. In this image you can make out the dyskeratotic cells. Whenever you see the epidermis, if it go up, it will become anucleated. But here you can see these kind of cells which are known as dyskeratotic cells, which are Corrons. Corrons are seen in spinous layer. The stratum corneum normally anucleated, but you are able to see some nucleated cells here also, which is grains. They can ask where Corrons are present, which layer Corrons are present in diarrheal. So you can remember, grains is always float. Grains float. So Rons will obviously sink in spinous layer. So that is very easy to remember. Apart from that, you have to remember the gene ATP2A2 gene. Smooth endoplasmic reticulum calcium transporter, that you should remember. The lesions are greasy, dirty papules in seborrheic areas. This is a Haley disease common in flexures. Here you can make out the dilapidated brick wall. The cells are separate, na? This is dilapidated brick wall. In flexures, the lesions will be fissures, crusting, and all will be there. The gene is ATP2C1. Okay, these two options we have discussed. Now we are left with psoriasis and pemphigus vigitans. In this, we may mistake in a hurry. We know psoriasis, there are two microabscesses. One is Monroe, another is Kogoch. Since there is a P, you should not think P for P. So the wrong answer here is psoriasis, portrait microabscess. We will see the microabscesses in dermatology. So it will be easy for you to remember in subsequent slides. Okay. Pemphigus vigitans is characterized by eosinophilic microabscess. That is correct. So the answer here is this one. Wrong pair is psoriasis, portrait microabscess. Now we will come to microabscess in dermatology. There are 5 microabscesses you have to remember: Monroe, Kogoch, portrait, eosinophilic, and papillary. First, we will see the location. It is very easy to remember. Papillary tip microabscess is seen in dermal papilla, right? Papillary tip papilla. Among other microabscesses, you should remember only Monroe, which is seen in stratum corneum. Others are seen in stratum spinosum. Only thing in the location you should remember is Monroe microabscess, which is in the corneum. Other things are directly given. Papillary tip microabscess is in dermal papillary tips. Spongiform pustules are in spinosum. Portrait is in spinosum. Eosinophilic microabscess is also in spinosum. So only thing I have to remember is this one. Next, we will go to infiltrate. What it is made up of. In this one easy clue I will give eosinophilic microabscess, na? So it will contain eosinophils. It is easy to remember. Eosinophilic microabscess contain eosinophils. Portrait microabscess contains lymphocytes. This one you have to remember. Here you have to remember this point. In microabscesses, portrait is different, which is containing lymphocytes. Other 3 are having neutrophils. Okay. So in the location, you have to remember Monroe microabscess, which is in the corneum. Other 3 are in spinosum. Papillary tip is in dermal papilla. In composition, only portrait microabscess you should remember lymphocytes. Others are having neutrophils. Eosinophilic is obviously it is eosinophils. Now we will come to the diagnosis. Monroe and Kogoch both are seen in psoriasis. So the wrong pair is psoriasis, portrait microabscess. Portrait microabscess is seen in cutaneous T-cell lymphoma or mycosis fungoides. Eosinophilic microabscess is seen in pemphigus vigitans, which is very important. Papillary tip microabscess or dermal papillary abscess is seen in a condition known as dermatitis herpetiformis. So if you remember in this way, it will be easy for you. The next question is, all are true about Langerhans cell except A, present in epidermis, B, derived from neural crest, C, it is an antigen presenting cell, D, presence of tennis racket shaped organelles in the electron microscopy. In this, we know there are 4 cells in the epidermis: keratinocyte, melanocyte, Merkel cell, and Langerhans cell. So we know Langerhans cell is present in epidermis, so it is wrong. And Langerhans cell is an antigen presenting cell involved in the immunity, and it is characterized by a specific organelles which is known as Birbeck granules or tennis racket shaped organelles in electron microscopy. Birbeck granules. So that is also not appropriate for this question. So the answer here is it is derived from neural crest. I will tell you how to remember the derivation. So it will be easy for you to remember. Most of you got wrong in this by selecting the option of neural crest, because it is derived from bone marrow. I will tell you. First, you will see about the derived from and function. Keratinocyte is a major cell in the epidermis which is involved in the structural integrity. Melanocyte, we know it is involved in the melanogenesis. Merkel cell is a mechanoreceptor. Langerhans cell is an antigen presenting cell. You know, antigen presenting cells are basically involved in immunity, na? So immune cells like WBCs, RBCs, those hematopoietic cells are derived from bone marrow. So the wrong answer here is it is derived from neural crest. Neural crest give rise to melanocytes, which is very, very important question. Melanocytes are derived from which portion? It is neural crest, super important. Other two cells are easy to remember. Both are derived from ectoderm. Okay. Only you have to remember melanocytes and Langerhans cells. Melanocytes neural crest, Langerhans cell in bone marrow, right? Now we will see the location of cells. Keratinocytes are present in all layers of epidermis. Melanocytes are present in stratum basale. Merkel cell is also in stratum basale. So in this also you can easily, if you remember Langerhans cell location, you can find out others. Langerhans cell is present in stratum spinosum, which is only odd man out. If you remember this, others are easy. Langerhans cell is present in stratum spinosum. Other cells are in stratum basale except keratinocyte, which is universal, all layers. So it is easy. Some special points in keratinocytes I have mentioned, which is involved in structural integrity. The IgG marker is cytokeratin. 5, 14, 110, there are multiple cytokeratins. Melanocyte, which is involved in melanogenesis. One important point is epidermal melanin unit. One melanocyte will supply melanin to 36 keratinocytes. That you should remember. One melanocyte, which is epidermal melanin unit. The IgG markers for melanocytes are S100, HMB45. For Merkel cell, which is a mechanoreceptor, slow adapting, involved in crude touch, the IgG marker is cytokeratin 20. That you should remember. The last one is Langerhans cell, which is an antigen presenting cell. It has a Birbeck granules, tennis racket shaped granules in the electron microscopy. That is a special point. IgG markers are CD1A, S100. The important thing you should remember is CD207, which is also known as Langerin. You can remember in this way. If you put the L in a rotatory manner, it will be 7. So L7. Okay, 207 is Langerin. These are the IgG markers. We'll move on to the next question. A 30-year-old male presented with the itchy skin lesions over the forearm and following nail findings. Which one of the following infection is associated with the condition? Option A, hepatitis C. Option B, hepatitis A. Option C is beta hemolytic streptococci. Option D is staphylococcus aureus. So first we will see the lesions are itchy skin lesions over the forearms and nail finding. First we will see the nail finding. If you see the nail finding, the nail is crumbled and the proximal nail fold is attached to the nail bed in a wing-shaped manner, which is known as nail pterygium. If you see nail pterygium, which condition do you think? If you see nail pterygium, the condition will be lichen planus. If you see lichen planus, the infection you have to remember is 1 minute. If you see lichen planus, the infection you have to remember is hepatitis C virus. Hepatitis C virus is more common in lichen planus. Sorry. 1 second. I'll put the slide again. There is a problem in the slide. So lichen planus, you have to remember hepatitis C. Hep C more than Hep B. Both are can occur, but hepatitis C is very important. Beta hemolytic streptococcus, if the option is given, you have to remember a condition known as guttate psoriasis. Next question is identify the bedside procedure. Option A grattage, option B Nikolsky, option C wood slump examination, option D diascopy. The image is given. Here a person is seeing red macules pressing with the glass slide. They can ask these kind of questions with the image, and they can ask identify the procedure, or they can ask something like what is the indication and all. If the person is using a glass slide to press and see the lesion, which is a diascopy. Okay, that you should remember. We will see the various things given in the option. This is diascopy. Diascopy is useful in purpuric lesions, which won't blanch. Erythema blanches. Apart from that, it is helpful in lupus, vulgaris, sarcoid. This you will see apple jelly nodules. That is important, diascopy. Apart from that, it is helpful in nevus anemicus. To diagnose nevus anemicus. Instead of pressing a lesion, if they are showing something like a scraping the lesion, which is known as grattage test. Here they are using a curette, or sometimes glass slide also can be used, which is useful in psoriasis. There will be pinpoint bleeding. This image you can make out now, which is known as Auspitz sign. There is no glass slide or curette. If the patient is just having some vesicles, the person is just stretching or giving a tangential pressure, which is Nikolsky sign. If they are doing in a normal looking skin, it is direct. They are doing around the lesion, which is indirect or marginal. It is useful in pemphigus, positive in pemphigus group of disorder. Pemphigus vulgaris, foliaceous, all pemphigus, you should remember. Due to acantholysis. That point is also you have to remember. And extra point is pseudo Nikolsky is due to cell death, which is seen in SJSTN. That you should remember. If they are giving some lamp, some blue light, if they are giving, that is Wood's lamp, which is useful in various conditions, various bacterial, fungal conditions, vitiligo, melasma and all. You will see the uses in subsequent slides because we have one question related to it. So the answer here is diascopy. We will move on to the next question. A 25-year-old male presented with abdominal pain 5 days back and took OTC medications for the same. Patient presented with following skin lesions for past 3 days. The patient had similar lesions at the same site 1 year back. The diagnosis is fixed drug eruption, erythema multiforme, Stevens-Johnson syndrome, drug-induced urticaria. In this, if you see, the option here is they took OTC medication and skin lesions over the same site after 1 year. So the site is fixed. Whenever the lesions appearing on same site, drug reaction, we have to think of a condition known as fixed drug eruption. But you can maybe confuse with the appearance. There are something like a target like skin lesions. But if you see, there will be central hyperpigmentation with peripheral erythema. Which is characteristic of FD. In erythema multiforme, there will be 2 or 3 zones. Erythema will be there will be pallor and all. It is not a Stevens-Johnson syndrome because there won't be erosions. There is no erosions. It is characterized by erosions. So that is a wrong answer. Drug-induced urticaria will have wheals. There is no wheals in this case. So in FD, you have to remember one thing, the site is fixed. What is fixed in FD? The site is fixed. The drugs are mainly NSAIDs, antibiotics, sulfa.